Welcome to Canine HS Bite-Sized Canine Anatomy series, and we are looking at the canine hip in this session. I'd like to welcome a warm welcome to everyone who's been following the series and supports Canine HS, and also a really warm welcome to all the new people that are signing in. We've had a record number in the last few of these series, so we're feeling it's something you're finding interesting and useful. And it is from the perspective of a canine therapist. So we will put some clinical tips in as well. So if you're new to this tech, it's really straightforward. It's a great bit of tech. So we have a chat room, which you can enter your chat on the bottom right of your page. And Sarah is very, very kindly supporting me remotely with the chat, because it's really hard for me to do all the tech, speak, sort the slides and read the chat. My first question usually is, can you hear me? Can you see me? The crowdcast, because of the huge use due to the pandemic, is a little laggy. So there is a bit of a 4 or 5 second lag behind. And so I'm going to give some extra time just in case you're typing out your questions. So don't put the questions in the chat box. If you could put your questions in, ask a question which is along the bottom navigation bar. And we've got 4 questions already, so please do add them. And I'm going to make sure that I answer all those questions. So we may overrun. I'm known for overrunning just a little bit, but we're trying to do this in a bite-sized 30-minute session. So I think we're going to start, and everybody's saying yes. I think you can hear me and see me, which is fantastic. I'll just bring up the slides. There we go. Hopefully you can still see me and hear me. And just welcome, we've got a really full house, and I'm just thrilled that so many people are connecting in with the way that we wish to work with the dog and not on the dog, and building this knowledge for those of you who've been following the series as well. It starts to overlap and starts to be more meaningful. So if you've seen the shoulder joint and you've seen the gluteal presentation, the gluteal muscle presentation, which is on YouTube, so you can find these on replay on YouTube, and we will have this replay available for you on YouTube in the next couple of days, hopefully by tomorrow night. And you can watch the replay straight away on this, and you just register into the same link. It's available a few minutes after. So it's a great bit of tech, but to be at the live event and ask your questions and have this interaction between each other in the chat box is brilliant. So I'd like to say a special hello to those in New Zealand. They've got up at 5 a.m. this morning. They've had a stormy, cold, wet night, and they've got their coffee and they're watching. So welcome, Karen. I'm delighted you've made the live event, and everybody else in New Zealand, and also to Australia. So we have a huge following worldwide, and it's so exciting that this community of canine focused therapists are signing in and building knowledge and understanding and reviewing and refreshing, because it's all about offering the very best service to the dogs in your professional care. So we're still in the UK, we're still in lockdown, and on the 7th of May, our government are going to kind of indicate some ideas of how we may start returning to work, but we're still in lockdown, and also we're learning to live with COVID-19. So just reaching out to everybody, a very silent, solemn moment, just anybody who's lost loved ones, family, friends, colleagues, NHS workers, frontline workers. You know, it's a heartfelt, we're feeling it for everybody globally, as well as in our own country. And it's just terrible times. So this is trying to look forward, and we're going to do a series as well. We've got some really exciting news in the next few weeks, how to help start building a way that canine therapists that are all about face-to-face contact, so social distancing, delivering a face-to-face service, is going to be very complex from now on. So we want to sort of help with that as well. So we're moving into the facts. Let's look at the hip joint, the canine hip joint, unique to this dog. And this is going to really help those who maybe have come from a different background. Maybe you've got a human training, maybe you're equine biased and based, and that's your species. It's really important to have the knowledge of the species that you're working with. And it's not just the anatomy. The anatomy is kind of naming and labeling. It's the functional anatomy. So the biomechanics, how the dog works, because if we understand fundamentally the dog's design, we can then offer the very best assessment and treatment techniques to these wonderful animals that we're so privileged to work with and own and have in our lives. They bring us so much joy. So looking at the shoulder joint, if you've seen that, there's a lot of comparable points here, but I'm going to identify the differences as well. So the canine hip joint is a synovial ball and socket joint. It's a spheroidal joint. The ball is the head of femur, the socket is the acetabulum, which is part of the os coxae, which is the hip bone. Oh, sorry, just going there, just showing you. So the green arrows are identifying the acetabulum, the socket, and you can see the depth of this compared to the shoulder joint. It's a really deep joint. And the blue arrow is indicating the head of femur. So I hope you can see that, but just the close-up is just to show you a little close-up there, because I really want to talk about the congruence of this joint and the stability of this joint because of this deep socket. So the joint range of motion anatomically, we can have flexion, extension, abduction, adduction, lateral and medial rotation. However, this doesn't happen in a dog's daily life because physiologically, so functionally, predominantly the movements that we see at this joint in the dog is definitely flexion and extension. And so for human practitioners, the background from where you're coming from, rotational elements are hugely important in human movement. Not so in the dog. The dog, it's about flexion, extension, and they are designed biomechanically to move forward in the sagittal plane. So when we're looking at the facts, functionally it's working, the range of motion is flexion, extension, then this should lead you to start using your clinical reasoning why you choose to use the techniques you do. We also know predominantly that the dog's movement, its balanced motion, is organized through different pathways, through different efferent pathways to humans. So this is a really important point when you're selecting your techniques and the types of techniques you're prioritizing when you work with the dog. So just to help you orientate yourself, if you haven't had a chance to see the gluteal or the gluteal crowdcast, the webinar, the purple arrow, and this is where, if you want to go and have a look at the quadriceps femoris muscle webinar in depth, this is where rectus femoris attaches to. So it's just cranial to that acetabulum. It's actually like a small circular flat surface, and rectus femoris, which is one of the parts of the canine quadriceps femoris, attaches there. The green arrow just above it, that's the body of the ilium. So the huge wing of the ilium with the Elliott crest then moves down into the body of the ilium. The brown arrow, which is to the right of the picture, I don't know if you can see this. I might just put that there. I know there's a lag, but if I just give you a bit of an indication there. So the brown arrow, that's the greater trochanter of the femur. And very important structures are going to be attached to such a significant, large attachment. I'm sorry. I have a reputation of calling things significant or insignificant knobs. So I'm trying very hard to keep it straight here. So the greater trochanter is something huge. And that means a really significant structure is going to be attached to it. And that's the gluteals. Now our gluteal muscle mass are incredibly important to the hip joint stability. I'm going to talk about that. They're not just extensors. They also are incredibly important in this stability, this dynamic stability of this joint in supporting the dog to move efficiently forward in the sagittal plane. So below that, right at the bottom of the picture, and again, we have a time lag, so I don't know if you can see the cross, but I'm just there on that blue arrow. That's the third trochanter, and in the dog, it's really insignificant. It's a very small mound. And the structure that attaches to that is the superficial gluteal muscle. So again, it's really worth looking at the gluteal muscle presentation or going on to our new Canine Anatomy Hub if you want to have some more depth and detail, just to kind of review that in a little bit more detail. And then up here, we've got the pink line. Again, I'll just run my arrow. I don't know if anybody is able to see that there. So the pink arrow is the lesser ischiatic notch, and the yellow arrow next to it is identifying the ischiatic spine, which sits around there. So just such an interesting structure. When we look at the hip joint, we have to look at the surrounding bony landmarks. We have to look at the surrounding musculature, as well as the supporting structures and ligaments of this joint. So this is a slide I've taken from the gluteal webinar as well, added a little bit more in here. So just to bring out some very important points. When we're palpating, so top clinical tip, if you look at the pelvis of the dog, you can see that it sits in the sagittal plane. This is totally different to the horse, totally different to humans. So if you look at the structures when you're looking at the iliac crest, so the iliac crest in the left picture is the bone between the two blue arrows there. Ventrally, it's quite thin. As you rise up here, it's quite thickened. And dorsally, it's really thickened like a ledge. And then the tuberous sacrale in the dog extends between the cranial dorsal iliac spine, which you can feel when you palpate, and the caudal dorsal iliac spine and the bone in between. And it is a ledge that your thumb literally can rest and sit on. So these are very important bony landmarks, the iliac crest and the tuberous sacrale in the dog. It's not significant or appropriate to be palpating the tubercocci in the dog because of the sagittal plane. It's a deep, uncomfortable plane. And the tubercocci there, sorry, I hope I said tubercocci. It's not appropriate to be palpating the tubercocci. It's very unpleasant. You don't need to. The muscles that attach there are sartorius, the cranial and caudal head, and then just behind it, TFL, the tensor fasciae lata muscle. Now, the tensor fasciae lata muscle, that comes up in the gluteal muscles and also comes up in the quadriceps femoris muscle. So here we've got, again, our greater trochanter, an incredibly significant structure. We know something incredibly important is going to be attached to that, and that's the gluteal muscles. So just to refresh our biomechanics of the dog has got 4 legs for 2 reasons. To support the dog up against gravity and to withstand those ground reaction forces, particularly the vertical ground reaction forces. And the second function of the legs is to move the dog forward, to accelerate the dog forward, and that's its design feature. So as we progress and you look at the other webinars, you've got to be asking yourself as a therapist, why would we even entertain any backward motion for the dog? The dog, like the car, is designed to move forwards. The car does not drive down the motorway backwards, but it does maneuver around a corner. So some backward motion is useful for maneuvering, but that's such a small part of the dog's natural balance motion. So all our therapy techniques should be thinking of working within the biomechanical design, not outside it, because research shows that working outside of biomechanical design and pushing a dog outside of its coping behaviors in your clinic leads to inappropriate behaviors, and also it threatens the function of that design. It puts excessive loading on it. So let's think of our treatment techniques binding in and being led by the functional biomechanical design of the dog. And again, I'm going to be raising in some future conferences and future webinars how important it is to work in the cranial caudal phase of joint range of motion. So there you can see the iliac crest between the blue arrows there, and then in the right picture there's the iliac crest. So really important to look at these structures laterally, ventrally, dorsally, to really understand the relationship between them all. The purple arrow there showing the sacroiliac joint, and the reason I've put that in there, it's incredibly important to understand that the pelvic limb in the dog, the hind limb, is attached to the sacrum, to the spine, through an incredibly strong coupling. And this strong coupling means there's a fantastic ability to transmit the power from the muscles. So the muscles generate the power through their contraction, the gluteals and the hamstring groups. And this, through the moment arms, is transmitted up through the spine, along forward cranially, so the dog is designed to move forward. It's a hugely strong coupling. So that makes sense and fits in with why the hind limbs, the pelvic limbs, slightly zigzag shape. They're fabulous for pushing. So the dog is designed to have its engine in the rear of its structure. It's a rear-engined animal. And the muscles that are directed by the proprioceptive system, what to do, when to turn on, how to work, the power muscles are going to be predominantly your gluteal muscle group and your hamstring muscle group. So incredibly important structures with around the hip as well to look at and explore. The lumbosacral junction here, I've kind of labeled that for you to really think about that. That's L7S1. Now, in different parts of the spine, so if you're interested in knowing more about the epaxials or the function of the canine spine, please put it in the chat box. We'll watch that feedback coming through, and that's maybe something we'll present in the future. But if you think of the spine as the drive shaft of the dog, okay, of the car, representing in the car that drive shaft, that the axle pushing, connecting the hind limbs to the forelimbs. That's the spine, that's the core. The cranial core in the dog has the ribs and a really strong intercapital ligament. However, the caudal core in the dog, you know, in those dogs with hip dysplasia, with hind limb problems, their core is an issue for them. It's not got that stability that it needs for the force of the movement to pass through it. So looking at how we can develop epaxial core engagement in the caudal core in a successful way and a productive way for the biomechanical design is really important. So Katie says yes to the epaxial muscles. Let me know if you're interested in that, because understanding the different function of the different areas of the canine spine opens up so many opportunities for you to select the appropriate assessment and treatment techniques for the lovely dog in your care. So I think you can go back to these slides as well. So here we've got on the left, the live dog, because that's what we work with every day in our clinics. That's when we're in work, that's the animal that we're working with. Let's remember it's a dog. It's not a human. It's not a horse. Don't translate your knowledge from another species onto the dog. The dog deserves our attention and study. And there, the blue arrow is identifying the hip joint. So again, finding these structures on the skeleton, practicing your palpation on the skeleton is such a top tip before you go and move on to the dog. So again, we're looking at these key supporting structures of the hip. So the two key hip supporting structures, there's a range of them, but the ones that enormously are important to the dog functionally are the cranial aspect of the acetabulum, that huge deep socket, and the ligament of the head of femur. Now, the ligament of the head of femur, depending when you learnt your anatomy, has different names. It's also known as the round ligament or the teres ligament. So the word teres means round. And it might be known as the round ligament of the head of femur. They're all the same structure, but I learned it as the ligament of the head of femur, and that's what I'm going to reference it to. So whichever wording you use, this is the structure, along with the cranial aspect of the acetabulum that is so incredibly important as a supporting structure of the canine hip joint. And the drawing I've got with the yellow arrow represents that little bit of plasticine there, represents this short, thick, flattened cord-like structure. It's not exact. We've made it slightly thicker and slightly longer so you could see where it lies. So please don't look at that and think that represents it. I've got a little bit more information later on that structure. So what I want you to think about with the cranial aspect of the acetabulum, you might be going, why is that more important than, say, the joint capsule or other structures? So I want you to think biomechanically. So if you can make a fist in one hand and then make a cup in the other. So your hand that's cupped up like this in front of you, that is representing the acetabulum, and that is the cranial aspect of the acetabulum. Because in the dog, the hip joint sits at between, some references say 95 degrees, others, the majority say 110 degrees, but across the species, 110 degrees. So put your hand up like that, representing the acetabulum, and this bit here, your fingertips, represents the cranial aspect of the acetabulum. Now get your hand as a fist and put it in there. So you've got opposition, all right? But I want you to push up into your fingertips. Now, when you push sharpen the fingertips, you will feel that the majority of the loading is happening under your fingers. Now think about the dog standing on land and moving on land. Its paw is connected to the ground and its head of femur is going up into that cup, into that deep, deep acetabulum, which is even deepened further by another structure we'll see next. And then because of ground reaction forces, predominantly the vertical ground reaction force and the mass of the dog and gravity, the loading predominantly is on that cranial aspect of the acetabulum. So this is key in the dog's stability. And it's key when you're looking at hip dysplasia. So hip dysplasia we'll mention at the end. I'm not covering that. So again, if you're interested in covering some conditions in depth, in some bite-sized canine conditions, let me know, because that could be a future series we could launch and relate that to this biomechanical knowledge that you're reviewing and connect the information together. So again, in the chat, just let me know if that's something you'd be interested in. So cranial aspect of the acetabulum and this amazing ligament of the head of femur, which we're going to look at a little bit more in the next slide, the two key supporting structures of the canine hip joint. There are other supporting structures that are very important as well, but they're the two key ones. So let's look at this deep acetabulum. It's totally different to the shoulder joint. When you look at the canine shoulder joint, you've got this small, shallow cup, the glenoid cavity, and you've got this huge head of humerus. It's absolutely massive, the head of humerus, but just a little cup. So it's got congruence, but it doesn't have stability. Whereas in the hip joint, it's totally different. It's got congruence, amazing congruence, but it's also got this deep structure to give it stability. And the deep acetabulum is further deepened by a labrum. Now in the shoulder joint, in the glenoid cavity, the labrum goes all the way around it to deepen that very shallow cup. Not so in the hip. In the hip joint, I want you to think of a horseshoe shape. So it's literally the labrum, which is a band of thick fiber cartilage, deepens the acetabulum. It's called the acetabular lip, and it's horseshoe shaped. So that is connected to the rim of the hip joint and deepens it further. Fantastic. And then in the left picture again, I've got the ligament of the head of femur just to show you its location. It's slightly thicker than it would be in real life. Now, in large breeds, that ligament, that femoral ligament of the head of femur is about 1.5 centimeters long. So like measure that out and see, you know, these are significant structures. So I'm looking at that acetabular lip. Now this is a brilliant design feature. Whereas in the shoulder joint, the rim is all the way round like a circular rim. Here it's a horseshoe shape. And the little bit that's missing is in the ventrocaudal area. And that is called the acetabular notch. So there's no labrum there. And there's a structure there that literally acts like a free ligament. So it bridges it. Like a bridge, it goes from one end of the acetabular lip to the other. Now, why is this so important? Well, we can now have structures going underneath it like a bridge, like water passing under the bridge, really important structures into this canine joint. So it's a beautiful biomechanical design to understand. And this structure that goes across it is called transverse acetabular ligament. So the acetabular ligament, the transverse acetabular ligament, and the acetabular lip gives you that complete depth for the acetabulum. Okay, so it's really important to understand this difference. So when we're looking at the ligament of the head of femur, it's mainly intra-articular. And it's also non-weight bearing. Now, this is really significant. So we've got to think, I'm telling you, this is a key supporting structure, but it's actually non-weight bearing. This is incredible. So let's have a look at the attachments. People get a bit confused with the attachments. So what I want you to do is think about the head of femur, make a fist, and then with your other thumb, as if you're just pushing in a print into that head of femur, you're going to make what's called a fovea, F-O-V-E-A. And basically, it's a shallow, just like a shallow cup, very shallow cup, and it's non-articular. So it doesn't articulate in the joint. So this attachment comes from the head of femur in a little fovea that is non-articular, and it goes to a non-articular fovea in the a fossa in the acetabulum cup. So if you make your cup with your hand and push your thumb in there like you make a little impression, and the fossa is bigger than a fovea. So the fovea is small, shallow cup, and the fossa is a slightly bigger cup. Both of them are non-articular. Now, what's really interesting about this ligament is its attachment in the head of the femur in a large breed can be about 5 millimeters wide. That's significant. Whereas the attachment in the fossa, so in the acetabulum, in the acetabular fossa, which is non-articular, it's wider. It can be up to 1 centimeter in a large breed. And it fuses with the periosteum, which is the bone covering. So that's like the sleeve of the bone. And it also fuses with that transverse acetabular ligament. So this is really anchored well. So I've got another slide just to have a little look at to understand what its main function is. And I think there's 5 questions sitting there. I had a little preview of just a sneak preview of the first 2. I think this is going to be really helpful for one of those questions. The main function of the ligament of the head of femur is about limiting range of motion in the dog. So if you think about it, it's connecting from the head of femur to the acetabulum, and it's non-weight bearing, and it's intra-articular, and it's a key supporting structure. And what it's all about is it's the limit of the end range of motion, and that's why it's so crucial. This is going to relate directly to some of the techniques I'm going to mention at the end. So here again, on the left, I've got a picture because it's so important. It deserves another page of pictures for you. And if you like the visuals, do let us know. We do the visuals with plasticine and pipe cleaners because we find for us, if we can visualize it, it makes sense. Whereas if I just read a page of script, I can read it 100 times. But if I see it, feel it, understand it, it makes more sense to me as a therapist. So do let us know if you like the way we present these. So we've got a drawing a diagram, a schematic drawing at the top to help you. And my favorite analogy for the ligament of the femoral head or the head of femur is I want you to think of those 2 plastic cups that you put some string through for a children's telephone. So if you've never done that, I'm really sorry. But one of my favorite things as a child, I put 2 holes in 2 plastic cups. I'd thread the string through and knot it. And then if you had it taut, you could talk to somebody. So I want you to think about this as a string that's loose between the head of femur and the acetabulum. And when it gets to the end of range, it's taut. And it's going to be a supporting structure and not prevent excessive movement at this joint. And this is where I just need to reiterate the most important part as a therapist, if you are trying to improve motion, trying to improve function, you've got to think of the power sweep of movement. So the power sweep of movement is the retraction phase. That's early stance, mid stance to push off. So the idea of the leg continuing off, the hind limb continuing off, and people calling that hip extension is not true. The fact is the key part is early stance, and it's mid stance to push off is the retraction power sweep of the dog. And so that's where we need to really focus where we're doing our treatment techniques. And this is reinforced by, if you look at the gluteal webinar, look at the function of the gluteals and look at the quadriceps and look at the function. We know it's incredibly important in weight bearing. And you don't have that if it's free behind you. What you do have is excessive force going through your lumbosacral joint. So understanding as a therapist to work within the restraints of the biomechanical model and activate the muscles in the appropriate part of their movement, of their range of motion, is really important for us, for this amazing species. So other hip joint supporting structures, incredibly important. The joint capsule. The joint capsule is this hugely roomy, fibrous, tough sleeve that goes around, and its attachments are to the peripheral of the edge of the acetabular lip. So just to the edge of the acetabular lip, that horseshoe shape, just to past the edge of that. Whereas on the femur, it goes beyond the articular surface. It goes a few centimeters beyond, and it's going to the neck of femur. And the cartilage covered head of femur, so it's incorporating that. So there are a few just bear with us. We did our best creating the joint capsule. It's pretty tricky without destroying our large skeleton, but we did our best to show that it's encompassing and going around. So a very important stabilizing structure for the hip joint. And now we're going to look at a group of muscles that are often overlooked, which is sad because they're small, but they really count. And as a group, they're incredibly important how they work synchronously with the gluteal muscles. So what we're looking at is the close association of the pelvic muscles. Now, when I mention these to other people in live debates and discussions, they weren't really aware at how close they are to the hip. They're literally just behind the hip joint on the caudal aspect. And they are a group of muscles, so they're worth knowing a little bit more about. I've put some extra detail in our canine anatomy hub, which I'll give you the link to go and see later if you want to have a look at a little bit more detail. But essentially, we've got these small muscles of close association. We've got the internal obturator, and I've given you the origin and the insertion, and I've tried to give you some guidance on the picture as well. But it is innervated by the sciatic nerve, as some of the others are. We've also got the gemelli, which are a pair of fused muscles. We've got quadratus femoris, don't mix it up with quadriceps femoris, quadratus femoris, and the external obturator. And as a group, they are the lateral hip rotators. Now, when we're thinking about a dog sitting down, when they sit down, there is a slight movement, and that's why the hip joint is brilliant. Not only does it give very slight abduction, but there is a slight rotation so the dog can sit in a comfy posture, and when it goes from sit to stand, but it's so minimal, the majority of the movement is flexion extension. So we want to focus on that as therapists. So this group here, if you have a look at their origin and insertion, that might take you a little bit more time. I've given you the slide. You can go through these slides again because in the Anatomy Hub, I've downloaded the PDF into it, so you can download your own PDF of these slides as well. Get your anatomy books out, really have a look. There is a little bit here that I'm unable to show you if I bring my arrow down, and that is the intertrochanteric crest. So the fossa, a huge dent, a huge sort of dip, just caudal here, between the greater trochanter and the lesser trochanter is the trochanteric crest. And this crest has been destroyed for the steel bar there to be put through it. So it should be a nice rounded U shape there, and that is the crest for people who are not quite sure where that is. So take time to orientate yourself and find these structures. Let's know all about these amazing stabilizers. They are a major stabilizing force for the hip joint caudally, but their key function is they oppose the gluteal action of medial rotation, because we come back to this amazing concept that the dog is designed to move forwards in the sagittal plane. So backward movement is not useful. It may be proprioceptively enriched, but it's working outside the biomechanical design. And that means you threaten the stability of it. Whereas if we work at techniques that encourage forward direction, whether it's static work, where we're doing some rhythmical stabilizations, or it's dynamic work and we're working in that sagittal plane, these are going to have the most dramatic, amazing effects quickly, particularly if you recruit the gluteal muscles. So the gluteals, as well as being the major hip extensors and the power, also some of them are medial rotators. And so this group of lateral rotators, if you think of a V, so again, make a V shape, they're working like a V shape. And what they're doing is they're maintaining that hip in the sagittal plane. Brilliant, a brilliant design. So now we're just having a look here on the top left picture. I'm just indicating where the hip joint is in this wonderful little terrier who was very patient with us with the photos, a bit distracted. But I wanted to reiterate how important it is to practice your palpation techniques and incorporate therapeutic handling. Now, therapeutic handling represents therapeutic palpation techniques, therapeutic touch, therapeutic holds, therapeutic lifts, movement shaping, alignment techniques. It is a range of techniques. If you want to know more about therapeutic handling, which is not just palpation, it's not just animal handling, there's a great short course. It's a bite-sized short course on therapeutic handling you can find on our website page. It's 6 hours, a review and refresher, and it is packed full of information about therapeutic handling. So again, practicing on your skeleton, and my thumbs, I apologize, they're a little bit my thumbs hyperextend naturally. So my hands are literally just resting on the bone. I am not pressing down. And I think the bottom right picture looks like there's a bit of pressure there. There really isn't. So the top right, my thumbs are resting on that tuberous sacrale. And you can see, this is so important, that the hips, they're in the sagittal plane. Okay, they lie in the sagittal plane, as does the pelvis, as does the os coxae. In the bottom right, my right thumb has moved across from the tuberous sacrale and caudally, slightly caudally. So if you're on the tuberous sacrale, when you come over centrally, you're about L5, depending on the breed and the dog. And so L7, S1 is the lumbosacral junction. It's got incredible flexion and extension, and it's very easy to hyperextend and hyperflex this section as well. So you have to be very mindful the postures that you're using for your therapy and for your assessment and treatment. So that's just showing my right thumb coming across, and you can feel it. Top clinical tip. It feels like a polo. It feels like a hole. There's a little fossa there. Okay, so you know where you are, and so you know if you go caudally, you're now on the sacrum, on S1, which is fused, 3 fused bones. And the bottom right is my thumbs resting on the tuberisci, which is also called the ischiatic tuberosity. So I tend to call it tuberisci. Again, same structure, different names, reflects when you learnt your anatomy. So just going to the next slide, again, just showing you on the top left, look how huge that tuberisci is. It's huge. And in dogs, where my thumb is, where my right thumb is, that's the bit you'll probably feel in well-covered dogs. But in greyhounds and, very fit animals that are well-muscled, you can palpate the whole length of that tuberisci. So if it's that big, something really significant's attached to it. This is a significant knob. We're going to have a significant structure, and that's going to be the hamstring group. The hamstring group share the power generation with the gluteals. So in the top right picture, we've got thumbs there resting on the lumbosacral junction, where I've gone to, first of all, I find the crest of the ilium. So I find the ischiatic crest. I then find the tuberous sacrale, and they are my landmarks to orientate me on the dogs. And I never just go and find them. What I do is introduce myself with therapeutic handling. I'm going to palpate the capsules with therapeutic touch, and then I'm going to find them because I don't want the dog to change its muscle tone because of the palpation reaction to general animal handling or palpation. So you can find the deepest structures with therapeutic touch. You just have to work with the tissue and not go on the tissue. So the bottom left-hand picture is my left thumb there. I wanted to show you if you're on your tuberous sacrale, so you found your iliac crest, you've then found your tuberous sacrale. If you drop your thumb medially, just medially, you're going to be sitting on the dorsal sacroiliac ligament. So the sacroiliac joint has a dorsal and ventral sacroiliac ligament. The dorsal one's a significant one, and that's where we could palpate that as well. So the bottom right, again, another series I'm thinking about, I'm getting really excited about. Would you be interested in a series on clinical assessment techniques? And this is one of the few assessment techniques that we would use when we're looking as a differential between, is it a lumbosacral issue? Is it a sacral issue? Is it a hip issue? If you, with your hands, so with your thumbs and fingers like that, your thumb is going to be on the tuberisci. Your fingers are going to be just drawing a line to the tuberous sacrale, and you're going to look at that distance, and is it equidistant, and is it level? And then if you move your fingers from the tuberous sacrale to the greater trochanter, you've got a differential, because that's going, so within the sacrum, you're all on the sacrum. You've got your thumb on the tuberisci, and you've got your fingers on that tuberous sacrale. That's within the sacrum, within the pelvis. The moment you move your fingers onto the greater trochanter, you've gone across to the femur. So that's going to give you, and if that distance is different, and there's some others that we can use as measures as well, but these are really interesting ways to examine the dog in a clinic in context of a therapy session. So, you know, I think that's just to relate this, get this information in your fingertips on a skeleton, practice on a skeleton, then move on to the dog. So questions, we've got 5 questions there. I'm going to start with that. So with the questions, if you've not had a chance to go in there, if you go in now, I'll give you a few seconds. If you want to upvote, so that means you can vote for your favorite question, because I'm going to start with that question first. The moment I go in and start reading, if you can stop upvoting, because what happens is the question suddenly moves away from my vision and up comes the next one. So if you want to go in there, I'll just give you a little time. We'll just go back to that last slide here, just again to give you, there we go. So the hub, I think Laurie's just coming in. Where can we find the slide? So the hub, the Canine Anatomy Hub, I'm going to tell you. So if you've finished with what you've got your information and you want to go, absolutely fine. If you want to go through the questions, brilliant, we'll go through the questions. I know I'm out of time. And then if you want to stay on, I'm going to tell you where to find the Anatomy Hub. But if you've got what you want, please do go. There's no problem. I'm not going to be sharing anything else just then now discussing the questions. So I've no problem if you want to, you know, zoom off, because I know it was a 30-minute slot and I've pushed the time as usual. Right, I'm going into the questions. So we've got 5 questions there. So 6 votes for the first. So I'm going to timestamp it. Please, can you not upvote now? And the timestamp is something you can find later. So if you want to go just back to the question, it's a great bit of tech. You can do that. So I'm just timestamping it now. Oops, another one's moved up. So just don't vote for the moment, please. So that's changed. Right, this is from Paul Watts. Right, so 6 votes. I see a lot of elderly OA patients with lack of mobility in the hips. Are there any non-obvious do's and don'ts that you could recommend? Absolutely. Sarah and I are so excited. We've been working on a new project recently, and we're going to share that with you over the next couple of weeks. And we are passionate about the senior dog, and we've got some really exciting opportunities coming out. And so this is really close to my heart. We see a huge number of dogs, and they're elderly, ranging from sort of like 8, 9 up to 16, 17. And the most important thing when you're looking at these dogs in the hydrotherapy setting and the physiotherapy land-based setting, do not push their hip range of motion, because what you use every day for your general day-to-day activities as an older dog is mid-range of motion. So in a short time, you've got an opportunity to make a huge impact on the older dog. You should not push their joint to the end range, just like you wouldn't with an older person, okay? You should be working at developing a really strong mid-range of motion, because the mid-range of motion is what they use functionally for all the activities that really count to dogs. So don't get carried away, because you could make the dog a lot stiffer. You could even take it off its legs. So working within that mid-range. So be very clear where early stance, mid stance and push off is for that dog. Feel the joint and feel the quality of the range of motion and work in that mid-range of motion. I hope that helps. That would be my main thing to get across. Work with the dog, not apply the techniques onto the dog with well intention, but actually take them out of mobility and take them out of balance because you've been too aggressive. You've got to work within the structures and understand aging structures respond totally different to younger structures. Muscle tone naturally changes, okay, with aging, as well as if they've also got an underlying condition. So respect the connective tissues that you're working with. I hope that helps. So I've got Paul's name there. So Paul, if you want to just let me know if that's kind of answered your question. My next question, we've got 7 votes for, so I'm just going to start answering. So Paul, if you're listening, please let me know in the chat if that's kind of answered or if you voted for that. Do let me know if that's helped you with that question. So I'm just going to start answering Sandra's. Hello, Sandra. I have heard that swimming is not good for HD, which I presume you mean is hip dysplasia. So I don't know if everybody knows the abbreviations. Could you shed some light on this? Thank you. So it's a very important question, Sandra, and this is really important. We need to differentiate swimming activity, a social activity, from hydrotherapy. Hydrotherapy, therapeutic hydrotherapy, is not about walking a dog in a treadmill or swimming a dog in a pool. Historically, they may have done laps and swam a dog, and historically, they may have randomly walked a dog in a treadmill with no one in it. We know that current therapeutic hydrotherapy is about connections with the dog in a warm water environment, and it's what the person, the therapist, the qualified therapist, creates with that professional bond and works with the dog. And each dog has a devised individual program. So I'm not sure if you're talking about swimming in a lake or swimming socially, and I also am not sure what age the dog's going to be. So it does depend on the segment of the dog as well. So in a hydrotherapy setting, using alignment techniques, therapeutic handling, in a young dog, middle-aged dog, and older dog, a sequence of movement that you control and guide is hugely beneficial for dogs with hip dysplasia. And a hip dysplasia, when it's active, is a growth disorder. So it's a condition the dog has when they're growing. So if we're talking of the older dog, they had hip dysplasia when they were growing, they will now probably have secondary osteoarthritis. So just to differentiate that, you have a dog who's 12 with hip dysplasia means they had hip dysplasia when they were growing, because it's a growth disease that the dog has. It's an incongruence. So with hip dysplasia, the key thing is, when we looked at those ligaments, is lax ligaments, where what happens with lax ligaments, it's lots of things happen. Usually with dogs, hip dysplasia kind of arrives about 5-6 months into their life, when they have a big growth spurt between 6 to 9 months. And lax ligaments is where you lose that opposition, okay? And so essentially it's lax ligaments. So if you want to know more about hip dysplasia in another presentation, we definitely would love to do that, because there's so much to share and how we connect that with the treatment techniques we choose. I hope that helps, Sandra. If you felt that useful, please do put it in the chat. I'm sorry I'm overrunning, but I really value your questions, and I really want to answer everybody's question. Right, so, whoa, topical. Okay, so this question comes from Jeanette, and I'm going to timestamp it. So Jeanette has asked me, are you saying that dogs should not be walked backwards in a treadmill? I am categorically saying, as a biomechanist specialist, as a physiotherapist that specializes in dogs, as a physiotherapist, as a lecturer at level 7 on master's courses at the Royal Veterinary College for 10 years, as a researcher, I do the job as a hydrotherapist. I move the dog in the biomechanical design, which is forwards in the sagittal plane, or I work statically to activate the muscles that are the power of that movement. I have never walked a dog backwards, and I would not put or jeopardize the biomechanical design with the extra stresses that entails at the caudal cruciate ligament, at the stifle, at the lumbosacral junction. So I hope that's really clear. But for me, with all the research and all the privilege of working with so many amazing professors, biomechanists, I would definitely always work with the dog forward in the sagittal plane. If you're training a dog and you train them to do a technique where they're taking a step backwards to training for like to music, you know, dance to music, that's totally different. I'm doing this from a therapist point of view that wants to improve motion and improve movement in the short time frame that I have with that dog in their weekly kind of life. So I need to make the biggest impact on it. So I hope that's really clear, Jeanette. Do let me know if I've made that clear. I have another question here from Michelle. Again, if you just pop that, Jeanette, in the chat, if that was useful for you, just to define that answer, because it's very important. So, Michelle, your question is, I'm new to the canine world, but in a human part of my assessment would be end feel. Even with therapeutic touch, is this something an experienced canine therapist would do? Would you feel in a similar way, or consider not useful due to potential pain trigger, change of emotional state in the dog? What a brilliant question. Thank you, Michelle, for asking that. You need to work with the dog with therapeutic handling, therapeutic touch, not general animal handling, not restraining an animal, but working with tissue. You are building a professional connection with the dog in context. And for that, in a clinical setting, you need to use clinical enrichment. If you want to know more about the amazing clinical enrichment treatment techniques we're using to get the amazing results that we get in a very short period, again, there's a great bite-sized short course on that. It's 6 hours to review and refresh on that. It will give you so many ideas of how to work with the dog in the clinical setting and in the hydrotherapy setting. End feel, I want to feel the quality of the feel, and I'm going to consider the signalment of the dog. So it's breed, age, sex, coat color. I want to know about that breed. I'm also going to analyze the dog's behaviors in the clinical context. So I'm going to be very respectful of the dog's behaviors in a clinic setting, totally different to their behaviors at home. And I'm not reflecting on what you would do with your dog in any way. These are dogs that are coming to you because they have issues, and you're working with them to improve or optimize their movement and their functional abilities. So you can go to end range if you wish, but you've got to be responsible for the structures that you will damage if the dog pulls with you and isn't compliant. So I'm looking at the quality of the range. I'm considering the range I want to work in. And I hope, Michelle, that gives you some answers, but it's totally different to working with a human, definitely. Karen, I've got a great question from my friend Karen in New Zealand. So we've had 2 votes for that. Karen got up at 5 a.m. this morning, and and it's the winter time. I think it's coming up to winter in New Zealand, and we're great friends. And she runs, she's a satellite centre in Auckland for our level 3 certificate in canine hydrotherapy, and an outstanding therapist. Her question is, my 7-year-old German Shepherd with bilateral hip dysplasia has an audible and palpable clunk from mid-stance through to hip extension. So mid-stance to push off is probably where I'm going to be really analysing that motion, because it may be that it's going beyond push off where the dog has got a kind of lag or a drag, being a German Shepherd. So again, we've got to think of the movement of the dog. We need to understand the conformation of that particular German Shepherd, that assessment. Would static work in the underwater treadmill be more beneficial than dynamic at this point? So what we want to do is we want to recruit those gluteal muscles and those hamstring muscles, as well as engaging those supporting structures in a really beneficial way. So definitely static work with a dynamic motion in there, just a dynamic tensioning, which is something we can explain if you're interested in having something about treatment techniques in a bite-sized group of series as well. So we've got lots of ideas where we're going to go forward this year. So that's something, PM me, Karen, we'll go through that, but absolutely hugely beneficial, because you need to look at the gluteal muscles and the hamstring muscles and how they actually function for the dog. I hope that helps, Karen. Do let me know. So that's gone through the questions. I'm going to just move on to the next slide. I'm just going to bring up a link. So I've had quite a few queries with, I'm really sorry, I've really overrun today, but there's just so much to share, and I just don't want to shortchange you and answer. I want to answer all your questions. So the Anatomy Hub, people have been asking because they've not found it. So the Anatomy Hub is something we're offering in this lockdown period, and it's free. If you like it and you feel it's been useful for you, if you wish to buy us a coffee, what we do is we use that money to pay for the tech to offer you this for you. But it's how you feel. If you don't feel this webinar has been useful, you're under no obligation to buy us a coffee. If you go to the hub and you feel it's not useful as a resource, again, you don't have to. But if you felt it's been useful for you, if you felt it's reviewed and refreshed information, it's given you another perspective for your treatment techniques, please think about buying us a coffee. And what that is a feel as you, sort of an emotional feel, this has been useful. It's £3, and it will help towards some of the tech that we're using. And we spend about 3 or 4 days actually creating these. So they take quite a lot of our time as well. And we are committed in our lockdown period to doing one of these a fortnight. So the Bite-Size Anatomy Hub, if you want to find that, there's a green button underneath the screen that I'm talking there. If you just look down, you click on there, you will go to an Anatomy Hub, and you can download the PDF that I've been using. There's extra notes, there's extra details on those pelvic muscles of association, there's some extra clinical tips, some extra photographs. So again, just you know, let us know if it's been useful for you, but it's open to you all while we're in the lockdown. If you wish to support us and see more videos, so we've got some really good ideas for some YouTube videos for us, and you haven't realized we've got a YouTube channel, please visit K9HS on YouTube. And if you like them, please subscribe and click like. And you can also sign up to a bell. So what that does is you will get a notification when we upload some new content, and we try to upload something, you know, every 2 or 3 weeks. We're just a bit pushed for time at the moment, but we're trying to keep up to that schedule. And again, if you want to claim your certificate, it's not an obligation, but if you'd like that opportunity, we have put a small fee on there because it actually costs us £3.50 to generate one certificate for one person. And we have provided them for free for a year. And so if you want the CPD certificate, again, you know, it's just a small amount to go towards you getting an amazing certificate, but you can write your own. You don't need to have that one. So it's an option. So I hope you've enjoyed it. Again, just giving us some information. So the last thing is I have released the scapular-thoracic joint webinar just before I went live this evening. It's on your Crowdcast. So if you go to the Crowdcast channel, you can click on it and you can reserve your space on there. So we have 100 free slots. So in our live event. So if you want to be up there first, I'm telling you now, so you get priority before we send it out through our messages system. It's on the scapular-thoracic joint, and this is incredible. This is a synsarcotic joint. It's got an incredible impact on the function of the forelimbs of the dog, and tying it in with the hip joints, tying it in with the sacroiliac joint and the biomechanical design, it will give you the complete understanding of how this dog moves. So I hope you've enjoyed it. Please keep safe, everybody. Keep well. And I'm thinking of everybody in every country worldwide. Please keep safe. And it's been great sharing this evening with you. And I do apologize for overrunning, as you know.